Have you ever wondered why radiotherapy is used instead of surgery for some patients, and why cancers may recur even if radiotherapy is given to very high doses? In this video, I will discuss how radiotherapy works, why it is sometimes successful, why it sometimes fails, and how it can also be used to help improve cancer symptoms in patients with incurable cancers. My name is Dr. David Stewart. I'm a medical oncologist in Ottawa, Canada, and a professor of medicine at the University of Ottawa. And I recently wrote a book called A Short Primer on Why Cancer Still Sucks, intended for patients and available through Amazon Books. This is the 5th out of 16 videos that I'm putting together to present some of my opinions on the things that people often ask me about cancer. And for additional details, you can see my book. Importantly, you should rely on your own healthcare providers for guidance on anything related to your personal individual health. With radiotherapy, a high-energy beam is directed through a tumor, and it can break the tumor cell's DNA. That may kill the tumor cell, although in some cases the damage can also be fully repaired so that the cell does not die. Generally, the radiation is directed in from one side of the body and passes all the way through the body and out the other side. So it hits the tumor in the middle, but also normal tissues on the way in to the tumor and the way out of the tumor on the other side. In addition to damaging tumor cell DNA, radiation will also damage the DNA in normal cells. But particularly at lower doses of radiation, normal cells are more efficient at repairing the damage to the DNA than tumor cells are. And that's why radiation can be helpful at treating cancers at doses that are also tolerable to normal tissues. In addition, radiation physicists use very highly sophisticated computer programming to plan the route of the radiation through the body to try to hit the tumor itself at a very high dose and hit a little bit of the normal tissue around the tumor where the tumor cells may be infiltrating, but to do the least damage possible to normal tissues at the same time that it's hopefully eradicating the cancer itself. Generally, the bigger the cancer that's being treated with the radiation, also the bigger the area of normal tissue that is also hit. And the ability to tolerate radiation is dependent both on the dose of radiation that's used and also the size of the area of normal tissue that is hit by the radiation. Overall, the dose of radiation that can be tolerated is determined by the amount of normal tissue that's hit and the dose of the radiation to that normal tissue. For tumors that are relatively small, like less than 3 to 5 centimeters, a special technique called stereotactic radiotherapy can be used, where individual beams of radiation come in from multiple different sides of the body, and they all sort of focus or coalesce on the area where the tumor is, so that a large amount of normal tissue on all sides of the tumor is hit with a low dose of radiation, but usually ones that it can tolerate, whereas the tumor itself is hit with a very high dose because that's where all the radiation beams are focused. There are also some other special types of radiation. For example, there's one called proton beam it sort of acts like a depth charge where the radiation comes in from one side, does not do a lot of normal tissue damage, then discharges all its energy right at the tumor, and then there's little energy on the far side. So it's a way of just concentrating the radiation in just one area of the tumor without damaging a lot of the normal tissues to a large extent. So proton beam therapy is very sophisticated, very expensive, so that there are only a few places that can offer it, unlike more traditional types of radiotherapy. Another special type of radiotherapy is called brachytherapy. With it, radioactive seeds are implanted deep in a tissue, and they give off radiation that damages the cells around them. So it's another way of localizing the radiation to the tumor itself. And after the radiotherapy is completed, then the radioactive seeds are removed again. A radioactive atom can also be attached to a monoclonal antibody, and the monoclonal antibody then goes through the bloodstream and attaches specifically to antigens present on the surface of the tumor cell, and then holds the radioactivity there. So it's just another way of directing radiation more precisely to tumor cells. While a cancer patient may be cured by radiotherapy, there are two major reasons that radiotherapy may fail to cure cancer. The first is that the tumor cell may repair all the damage done and thereby survive the dose of radiation. The second is that there may be tumor cells outside of the area that can be seen that just are not hit by the radiation. And so the initial tumor may be completely eradicated, but then other tumor deposits may show up at a later point in time as they grow. As a general rule, rapidly growing tumor cells are more likely to be killed by radiation than slowly growing tumor cells. However, the rapidly growing cells, if they survive it, they can also grow back rapidly. And so that if they're not killed, you could get a quite rapid recurrence of the cancer. If the cancer begins to shrink with radiotherapy, then the remaining surviving cancer cells have less competition for nutrients, and therefore they can actually begin to grow more rapidly if they survive the radiation because of those additional nutrients. And that's referred to as accelerated repopulation. I mentioned earlier that normal cells may be better at repairing radiation damage than tumor cells are. And that's one reason that radiation is typically given 5 days a week over 6 or 7 weeks, because at that low dose rate, there's a greater difference in the ability to repair the DNA damage between the normal cells and the tumor cells. But on the downside of it, during that time period, the surviving cancer cells are beginning to grow more rapidly, and so that you can then get accelerated repopulation. So that's why the radiation is not typically given for longer than about 6.5 weeks, because if you give it over any longer than that, then the benefits of a low dose damaging the tumor and not the normal cells, that's overcome by the impact of accelerated repopulation, leading to an increased risk that some cancer cells will survive. So oxygen makes radiation more effective at damaging DNA and killing tumor cells. But many cancers have abnormal blood vessels and therefore abnormal delivery of oxygen or not enough oxygen. And this is one reason that cancers may be resistant to radiation and may survive radiotherapy. Chemotherapy is often given along with radiotherapy because adding chemotherapy to radiotherapy for many cancers improves the chance of cure by a few percentage points. The chemotherapy may directly kill additional tumor cells, or it may kill tumor cells that are outside the path of the radiotherapy, or it also increases the probability that the radiation will severely damage the DNA in the tumor cell and thereby kill the tumor cell. For most localized cancers, surgery will generally have a somewhat higher probability of eradicating the cancer than radiotherapy. But if the patient cannot undergo surgery because they've got medical conditions that make it too dangerous to try to operate on them, or if the cancer cannot be completely removed because it's invading into surrounding normal tissues, then radiation may be a useful alternative that may be able to cure the patient. So it is a good alternative to surgery in many patients. In addition, if a patient has only a low probability of cure by surgery because of the size of the cancer or other factors, then it may be felt that the potential complications from the surgery would outweigh the potential benefit and the probability of being cured. So there's less of a downside to giving radiation. So you can give high dose radiation. It still may not cure the patient, but at least there's less lost by it in many patients than if one is treated by surgery where there's a higher risk of complications. When radiotherapy is given, it can cause both short-term complications and long-term complications in the normal tissues in its path. The short-term complications are typically in rapidly growing cells, and so it creates inflammation, like a bad skin burn or a bad inflammation of the esophagus or things like that. And these toxicities can last for a period of a few weeks to several weeks, but then will typically clear up to a large extent. Many patients may also experience fatigue as a result of the radiotherapy. Long-term complications tend to occur in more slowly growing tissues, but they're also there long-term. So it can damage blood vessels, and that damage to blood vessels means that there could be a decreased ability of the tissues in that area to heal if there's any other thing that happens like surgery. Or it can lead to a chronic ulcer in the skin or other things like that, or bad scar tissue in the lungs, so that there's increased shortness of breath because of the damage to the lungs in the path of the radiation. If it damages the spinal cord, it will occasionally cause permanent paralysis, although the radiation oncologists are very careful to try to avoid hitting the spinal cord with a dose of radiation that would be likely to cause that. In addition, in the brain, it can cause long-term problems with memory if high doses are given, or there's a small possibility of what's called radiation necrosis, which is an area of dead tissue in the brain in the area hit by the radiation that can then cause problems later with increased swelling or edema or seizures or other things like that. If the heart is hit with high-dose radiation, there can be impaired heart function chronically after that. Or also, in fact, a small proportion of patients may also develop late cancers that are caused by the radiation itself. I mentioned that if the blood vessels are damaged, that could cause a chronic ulcer or sore, or could interfere with healing. It can also lead to development of what's called a fistula, which is an opening between two different areas of the body. For example, an opening between the trachea or windpipe and the esophagus is what's called a tracheoesophageal fistula. That can be a major problem if it happens, because then as somebody eats food or water is going from the esophagus out into the lungs and causing coughing and pneumonia and chronic infections. Because of the limits of how much radiation normal tissues will tolerate and the risk of long-term major complications, radiation oncologists are very, very careful in the doses of the radiotherapy that they give to any area of the body. So that the radiation physicists are a key player in this, very carefully planning what dose of radiation each area will receive with a given dose of radiation. And also the radiation oncologist will then often put a tattoo on the skin of the person to outline the area which was treated with the radiation, and that they can thereby try to avoid retreating with another high dose of radiation that might increase the risk of major long-term complications. However, no matter how carefully the radiation oncologists and radiation physicists plan things, a small proportion of patients may have major long-term tissue damage from the radiation. Just like when people undergo surgery, many people come through it fine, but there can be major long-term complications as well. These are things that fortunately don't happen to most people, but there's always a small risk of them occurring, and these are taken into consideration when advising patients on whether to take things like radiotherapy. Some patients will have a small risk of toxicity, and other patients will have a high risk. And again, for example, the bigger the area that has to be treated because of the bigger the cancer, that increases the risk of major complications. Also, if the patient already has impaired function of an organ, that could increase risk. For example, the patient has bad emphysema and they require high dose radiation to the lung for lung cancer, then they might run into problems because of the added damage to the lung by the radiation superimposed on the chronic problem of the lungs from the emphysema. Also, some patients with other diseases will have an increased risk of reacting to radiation. For example, patients with what are called collagen vascular diseases, which are inflammatory diseases like scleroderma, will have an increased risk of major lung inflammation that can be life-threatening or fatal compared to people that do not have those conditions. Or anybody with pre-existing pulmonary fibrosis or scarring of the lungs will be at increased risk of major long-term complications in the lungs from radiation. And again, the radiation oncologist takes this into careful consideration when deciding what can be done for an individual who may benefit or require radiotherapy. Even if a patient cannot be cured by radiotherapy, they may benefit a lot from lower dose, what is called palliative radiation. And so, example, for an area that's painful, it can help a lot with control of pain. Or if a patient's coughing up a lot of blood from a tumor in their lung, radiation to that tumor can reduce or eliminate the bleeding. If a patient has a painful bone metastasis or a risk of a bone breaking, this risk can be reduced by radiation to that area. This improvement in symptoms can substantially improve a patient's quality of life. While curative radiotherapy is typically given over 6 or 7 weeks, palliative radiotherapy is often given at a higher dose over just a very few treatments, either just a single treatment or over 5 treatments, because with the total doses being given, the normal tissues will tolerate this and makes it much more convenient to patients to get the dose over this shorter time period. Overall, radiotherapy can be very helpful. It can cure some cancers and can very help in a major way with control of symptoms for other patients that cannot be cured. So it's a very important part of the treatment armamentarium with which we try to help patients. On this and other aspects of cancer, again, you can get more information from a book, A Short Primer on Why Cancer Still Sucks, available through Amazon Books. And I hope that this video has answered some questions and has proven helpful to you. Thank you.